Next session is by Dr. Mithun Bhartia. He is my friend. He is from Guwahati. Very dynamic and humorous speaker. He is an young sexologist from Guwahati. Has been awarded the Rising Star at the International Symposium on Diabetes held at Mumbai in January 2016, bringing pride to the Northeastern region. He has also previously been the recipient of Edswiller Scholar Award 2013-14 at the prestigious Mayo Clinic, USA, and the Rising Star Diabetes 2013 United Kingdom. He has also been awarded the Zongniti Newman Prize in Chicago 2013 by the International Society of Sexual Medicine for his work on testosterone diabetes and erectile dysfunction. He represents India at the Worldwide AGP Clinical Academy. Over to Dr. Mithun. Before that, we have a poll question. Is sexual dysfunction a stigma for females to discuss? It's an important question. Yes, no, maybe, not known. We'll wait for the poll result before Dr. Mithun can take over for his talk. Yeah, they say 67% say yes and 23% says no. So over to Dr. Mithun for your talk on diabetes and sexual dysfunction.
Thank you. Thank you, Dr. Ravinda, for the kind introduction. Thank you, Bansi Bhai, for asking me to speak here. He's always been a mentor and a guide, and thank you, Dr. Sasank Joshi, for the same. So my talk today is cut out, diabetes and sexual dysfunction. And the reason it's cut out is I'm the last speaker between a day-long, extensive, beautiful program that has been designed. So my job is to keep you entertained and yet provide some significant material to think of at the end of the day. So that's, am I audible clearly?
Yeah.
Okay, great. So let us start with this slide. Now, when I was at ADA in San Francisco a few years ago, I saw this beggar with this slide, a cat, a dog, and a mouse sitting together. Now, that was a revolutionary idea for me because I belong to the generation in which there was only one cartoon network, which was Tom and Jerry and Mickey Mouse. And I'm sure most of us colleagues belong to that era of television in which we saw this cartoon network. And for me, what was ingrained during my childhood that a cat and a dog can never be friends. Tom and Jerry can never be friends. And here I see a picture of a dog, cat, and mouse living together. It just changes the whole perception of my childhood memories and challenges the beliefs that I have actually grown up understanding. And this is, my friend, what is sexuality? Now, sex is something which we don't discuss during medical school days. We discuss off medical school days, but it's not part of our medical curriculum. We do not talk about sex with our parents. Most of us don't. And we have been told from childhood, anything that is related to the genital area is a very private affair and should not be talked about in public, to the point, I would say, and I could challenge this to all the audience that are living. I'm sure if you have a male boy in your house, you don't call his penis a penis. You call it by all fantastic vernacular names that may be possible, but you don't call the penis a penis. So this is how we have been brought up. And this is the way our outlook towards sexuality is. And the point is, once we become a doctor and we are sitting in our clinic, we try to endorse our beliefs of sexuality on the patients that are sitting in front of us and judge by our own values. So my dear friends, my first request would be, when you are going to sit in any clinic or you're going to talk about sex to any patient, take that out of the window and take your own growing up years, own perceptions about premature, premarital sex, postmarital sex, extramarital sex, whatever you call it, erectile dysfunction, premature ejaculation, orgasm, whatever your own concepts are, which are not scientifically based, out of the window, and give a a sympathetic ear to your patients. I think that goes a long way in helping the patients. Now, when I started my practice, so I'm an endocrinologist by profession or by training, and in India, endocrinologist term is not a very well-known term. People understand diabetologist who endocrinologist also treats diabetes, and diabetologist we mean person who treats diabetes. Very simple definition. Now, when I started my practice of doing sexual medicine, I trained in Oxford for that, and I used the word sexologist or sexual medicine across my name. I was a lot of senior endocrinologists and senior doctors called me up and said, do not write this word. You are insulting us. Please write the word andrologist, but nobody understands the word andrologist. People have a sex problem. People want to see somebody who can sort out their sex lives. And this brings an important view, in my view, is a doctor who is ready to train, ready to treat sexual medicine patients, be it erectile dysfunction, premature ejaculation, desire, orgasm, whatever you might call it. First, he must be comfortable in himself using the word sexologist or a sexual medicine expert on his board. If you are not ready to use the term there, you are yourself hiding in the shame of the specialty. How good are you to your patients and how good are you to the society? Now, let's bring another perspective here. Now, I'm an endocrinologist. I see a lot of diabetes patients, and so does a lot of senior physicians who are listening to this talk. What are we doing in our clinic? Am I being able to cure the patient of diabetes? I can't. My job here in my clinic is simply cut out. I need to keep reduce his glycemic variability, improve his quality of life, and reduce the risk of micro and macrovascular complications so that he can achieve a quality of life which a non-diabetic can. And sexual life is an important part of your quality of life. Now, diabetes, when there is stress in the ecosystem, you may lose your job, your wife might leave you, you may have a fight with people. Whenever there is stress and during financial problems, your diabetes may move up and down. And this causes anxiety in the patient. If your sexual life is not very good, if you're not good in your personal life, that spills over to your productivity in life as socially as well as personally. And this also affects a chronic condition like diabetes. So diabetes causes problems in sex life, and sex life problems can also worsen your diabetes, causing problems. Now, how did the story come around? When did the penny drop for me when I was in England? Well, I saw a young teenage girl coming in my clinic. I think it was a boy. I think we saw both. So, and both, we were trying to actually explain to them that, you need to get your act together for your diabetes to get it under control. And you could see they were nodding, but they were not really listening to you. And she said, look, you're talking about renal failure, eyes, kidneys, heart. I am 18-year-old. Does it really matter to me now? Tell me something that matters to me now. And he told me, I don't give a 4-letter word to your complication stories that you're going to grill in my mind. Once I talked about that it can affect your sex life, you could see the whole story turn, and he'd been attentive to what you were trying to tell you. Very often, when you're going to talk about sex, you can see people's concerns, ideas and concerns may be very different where they're getting the sexual dysfunction. The perceptions of the people married, they want sex to last 16 minutes because they've seen in a porn movie, that's how it lasts. They come to you and tell you, you just tell me, and my wife does not know that I have problems in my sex life. He forgets to understand that it's his wife who is having sex with, so his wife will definitely know what's going on, even if he does not want to talk to his wife. They go and have an extramarital affair and come back with a guilty conscience and cannot be productive in their sex life. And on top of that, Google Baba always causes more concern than help to us. Now, the point that I'm trying to make with this slide is PD5 inhibitors or any treatment for sexual dysfunction may not be needed in the large majority of cases if you're actually going to have a conversation with your patient regarding that. Now let us move on to the endothelium. There's good data that endothelial microparticles, circulating ones, are an emergent marker of endothelial dysfunction in diabetes men with erectile dysfunction, and the levels were increased in diabetic men as compared to other people. Endothelial activation markers and TNF alpha were negatively correlated with erectile dysfunction. Now, via a lot of pathways and oxidative stress, there is reduced nitric oxide bioavailability and an imbalance between vasoconstrictive and vasorelaxin intracellular pathways causing erectile dysfunction. Now, let us move to something very simple for us to understand. Now, why does one get an erection? Well, I say if you take a balloon and you blow air in it, the amount of air that goes in the balloon is how tight the balloon is. So amount of blood that comes in your penis is how tight the penis is, natural physiology. So if the blood flow is occluded for any reason, then there's going to be problems because of that. And there's an excellent paper by Montosi which show that is a 50% lumen obstruction will cause reduction and symptom development in that patient. Now, it is well-known fact that the penile artery is 1 to 2 millimeter, and the arteries of the heart and the brain and the femoral are bigger. So if you take a big pipe and a small pipe, the small pipe is going to get occluded before. And there's good evidence that erectile dysfunction in a vasculopathy presented at least 4 to 5 years before a myocardial infarction in a people. And if at that time we had taken guard, we could have reduced his vascular risk factors, reversed a lot of damage in his vascular endothelium, and probably would not have reached a stage of causing any problems in his heart, plus save the family life and a lot of money. Sorry. One of the person who's responsible for getting me into this sexual medicine is Jeff Hackett and Sudha Ramachandran, who were my mentors. And we did a trial in BLAST, which was on testosterone and diabetes. But they looked at the papers, and then they looked at retrospective consideration of the impact of PD5 inhibitors and statin. And they found that the estimated mortality probability of PD5 inhibitors, they showed that it improves the mortality when the person is treated with PD5 inhibitors as well as statins, and they were independent markers. Now, when we talk about PD5 inhibitors, it comes in a wide variety. I've got a slide to see what are the brands that are available in the market, but there is good evidence that administration of daily 5 milligram improves endothelial function in patients with benign prostatic hyperplasia. In fact, in LUTS, you can use tadalafil low dose, which is both going to help in the LUTS symptoms as well as erectile dysfunction. And there's a data which suggests that chronic administration of tadalafil improves endothelial dysfunction. More data which shows that PD5 inhibitors is associated with reduction in all-cause mortality and association between treatment for erectile dysfunction and death after myocardial infarction. There is a good association between that. I think we've got a slide. So let's come to this slide. So when you're going to go around for a PD5 inhibitors in the market, what are the things that are available, and what are the points that one should consider when they're going to prescribe this medication? Now, you have short-acting PD5 inhibitors and you have long-acting PD5 inhibitors. Now, even though in this slide I've got tadalafil 10 and 20 milligram, it is also available in 5 milligram and 2.5 milligram in the market. Now, as all of us would understand, that sex is a natural occurring phenomena. The moment you plan a natural occurring phenomena, the flow of things are not going to happen. You're not going to take a tablet of PD5 inhibitor, wait, and then say, "Are ruko bhai, आधा घंटा रुकने का है, उसके बाद ही होगा action." You know, life is not like that. If life was that simple, your wife, you would feel your wife. A lot of patients come and tell me that, "Sir, my wife feels it's very artificial. When I'm taking a tablet and waiting for 20 minutes, the mood and the flow that does not really come along." So tadalafil, from that aspect, we call it a weekender tablet, has a longer duration of time and can be taken on a Friday evening. Most people have sex on Saturday, Sunday. Though in COVID times, I would say it's very different. Every day becomes a Saturday and Sunday, but it actually gives you an endogenous blood level which can be exacerbated on sexual desire and foreplay and can do the desired effect rather than waiting for a tablet to happen. Important factor to know that whenever you're giving any PD5 inhibitors, please do not give in patients who are taking nitrates. I think that is an absolute contraindication for the patient to be given PD5 inhibitors. The other thing also, tadalafil in some people can cause backache. So it's very important you take a history of backache before you're giving prescription of tadalafil, because you would know whether to blame the tablet or not to blame the tablet. Sildenafil can, a lot of these tablets can cause flushing side effects, but I'm sure we can work that around when we are seeing patients. Now, what is the point I'm trying to make this slide? What comes in front of us is not always the full story. You know, a person who's well built, coming to you, talking to you, he may have erectile dysfunction. And generally, these patients, and diabetes, when we see diabetes in our clinic, it is generally a social phenomena. The brother comes, the mother comes, the daughter comes, somebody else, everybody is accompanied to come and talk to you about diabetes. And sometimes the patient drops certain hints in the clinic for which you should be able to get that. Something which I've found that they say, "Sir, bahut weakness lag raha hai." So he's not asking you for multivitamins. He's asking you that help me. I am not having a definite sex life. That is what the word generally means when they are all the time telling you, "Sir, I'm feeling very weak." It is not any multivitamin that needs it. You need to actually talk to him alone. Or if he says, "Sir, कुछ बात करना था लेकिन आज तो नहीं, we'll talk some other day." Or by going while on the way out, generally it's on the way out because they don't want to make eye-to-eye contact with you regarding that said. Now, coming back to the poll question, whether females have difficulty in asking. In fact, I would say most of the male patients that I see, I try to see them as a couple, but most of the appointments that are taken in my clinic are by the female patients, female of the male patient who call and book the appointment and kick their husbands to come and take for help. I think the world is changing. We need to accept Dr. Akhtar is here. And I think we actually need sexual dysfunction to talk about sexual dysfunction on the IDF platforms as well, to actually bring this to the light. Are we ignoring something which is very important for our patients in COVID times, where we are realizing we are spending more time in the house? A diabetic patient needs happiness in the house. People are realizing it's family that matters. Are we actually going to deprive and not talk about this to our patients under the thing that God, that if the patient has a problem, he will ask us, and we think patient does not have a problem, why open the Pandora box? Now, with that, I end my slide saying, over the years, during my training in endocrine, I have denied many patients a treatment for sexual dysfunction because I thought it was a whole placebo effect and it didn't really exist. It all started when my mentor, Dr. Mills, I was doing a clinic with him and he said, "Send this patient to Jeff Hackett, nothing might, and he will talk about it. And as a trainee, you really want to know what's going on." And that's how my game or my learning in sexual medicine started alongside endocrine training. So what I think is this is an important aspect of our life. We owe to our patients to tell that, and it needs to be talked about. Otherwise, we are missing something really important in our clinic. With that, I end my slides. Thank you so much. Happy to take questions.
Thanks, Dr. Mithun, for the wonderful deliberation. Over to Dr. Sandeep for further proceeding.
Yeah, excellent presentation, Dr. Mithun, and often ignored subject, but you are the best to talk about it. Before asking the questions people have asked, just I want to know, have you really seen a patient with the erectile dysfunction improving after improvement in the glycemic control? Have you really seen it?
So I think, Sandeep, that's a very good question. It does contribute. I would be wrong for me not to say it does not contribute. But very often you see a patient comes with balanoposthitis presenting as a new onset diabetes in your clinic. And at that time, he's ready to
नाम
go.
चेंज करो बंसी साहब फटाफट पूछ
At that time, sorry, at that time, he's ready to get everything under control. He's ready. And if you nudge him, the sugar control does contribute in my clinical practice. I've seen it does help. Is this the only thing that will help? No. As diabetes has got multiple pathophysiology, you need to attack the erectile dysfunction from various pathways. But yes, improving the glycemic control will help towards it, as does stopping smoking and improving his cholesterol profile.
What I mean was 10 years down the line of the diabetes, 10 years down the line.
I think we can plan a good study alongside IDF for the same. And Dr.
Thank
Akhtar,
you.
But Dr. Sandeep, the possibility is that the patient with the down the line with the 10 years of diabetes may have neuropathy also, the autonomic neuropathy. Erectile dysfunction is not just one problem. It's not just vascular problem, neurological problem also, along with a hormonal problem. I want to ask one question to Dr. Mithun, that is the low dose tadalafil is effective? Because we are using in some of patients 2.5 and even 5 in the low dose. And I'm using also in some of the patients with 5 milligram alternate day too. And it's like what you had said very rightly, many patients have complaint of kamjori hai. That kamjori mean we understand that what exactly the meaning of kamjori. But if we give them, they feel really good. Even the spontaneous erection which they get, it may not be just for the primary purpose of getting this intercourse, but even if they get a spontaneous erection, they feel really good and they feel that kamjori kam hui. Your opinion for that?
I think you're right. A low dose tadalafil often helps. You can give 5 milligrams. And if this patient, some people had side effects at 5 milligram, 2.5 is available by a few brands. We can give 2.5 or we can half the tablet. Sometimes also gets a patient's confidence up. Because I think it's like a cricket match. एक batsman is आपको बार-बार bowler out कर रहा है. जब वो bowler के हाथ में ball आएगा तो आपका confidence जा चुका है. So a patient who has erectile dysfunction, his wife comes to him, he runs away because he says अभी तो नहीं सामना नहीं कर सकता. So often that also, and sometimes you've been able to wean off the tadalafil as well in such patients. So 5 milligram tadalafil is a very good dose to actually try for some time for the patient and see what the patient gets and perhaps titrate it down.
Next question is for Dr. Akhtar Hussain from Dr. Ajita. She has asked it, which diagnostic criteria you personally feel better in diagnosis of GDM? You have to unmute yourself.
As you know that you know that the diagnostic criteria that was developed in India is probably more appropriate for our population, but still, so I will lean on it, but I think that there could be some potentialities for improvements, and which we need to see comparing, for example, the highest prevalence, and for example, DIPSI is giving us the lowest prevalence rate, and that would mean that we are saving a lot of money, and given the limited resources in terms of the physicians in our countries, so it will be possible in terms of the feasibility. But having said it, are we missing a lot of people? So what we have to see, that we have to look at the endpoints. What is the endpoint? Why do we treat GDM cases? We have to see this, for example, that we have to put that we have to look at this what I'm missing at the moment, that by taking for example, Carpenter and for example, the DIPSI, and taking these two study population with the end marks, with the endpoints, and then we have a follow-up study, for example, and then for a cohort of studies that will deliver at certain time, and try to look at this, for example, the complications related to the GDM, whether this has been reduced by taking, for example, this is similar that by taking that, for example, DIPSI, which will give us a kind of a 7% compared to 17 or 19% prevalence rate. Are we that false, these 12% that in between the 7 and 19%, these are false positives, or these are the false negatives which you don't know? And I will start with DIPSI. I think that my answer to your question would be, I will start with DIPSI with some caution that we might be missing some patients who needs treatment, and for which we still don't have the data. But given the feasibility of our countries like India and Bangladesh in terms of finance, in personal, because our finance is not like Norway, that which is being paid by the state, it is coming from the individual pocket, and the resourceful people, like the number of doctors that is available in the country, I will start with DIPSI.
Okay, next question, Dr. Sachin. Is a diabetes, like any type 2 diabetic patient, there are many patients coming with subclinical hypothyroidism. Do we need to treat all patients with subclinical hypothyroidism in the setting, in the background of type 2 diabetes?
When it comes to subclinical hypothyroidism, the guidelines are very clear. There are only few indications for treatment. And if a type 2 diabetic patient, definitely if she turns out to be a pregnant lady, already diabetes in pregnancy, definitely I'll be treating that patient. And if a lady is already having type 2 diabetes and she's planning to conceive in near future, and her TSH is somewhere around what, 6, 7, 8, and definitely I will see her TPO levels, and if they are positive, I will go for treatment. These are few subtle indications for where we are actually treating these patients with subclinical hypothyroidism. Vice versa, there is also one component with it. Majority of our diabetic patients are obese. And as I've told you, it is the obesity because of the leptin levels which go down. The TSH is borderline high in these patients. And there are a good number of patients. There are a good number of cases where we have seen, and we have seen this with even with Cushing's also, even with normal obesity, even with this like this. So metabolic syndrome patients also, they have got little bit high TSH. So if they're not falling into those special category where we are supposed to treat them for thyroid, they're not requiring any treatment. Majority of the times, if you lose weight, the TSH will be normal. Or definitely if the TSH is more than 10, you're supposed to supplement them with leothyroid.
Okay.
We have a question for Dr. Akhtar. What is the right drug to start in obese Asian patient with the gestational diabetes? Should we start with the metformin or insulin?
This, as I've said, that we with our tradition, we start with insulin, but we are seeing more and more that studies actually, which is mostly conducted in European countries and some in the United States as well, which I see the metformin is giving more or less similar kind of effect. But if you look at the postpartum complications treated with insulin and with metformin, it seems that there are lesser complications treated with metformin rather than those who treated with insulin. Even I have seen one studies where it has shown that, for example, the conversion from GDM to type 2 that came as follow-up, these numbers are higher in those treated with insulin compared to this metformin. So I think that we have reasons to believe that metformin could be safe, but still we still do not have sufficient data to recommend such a thing. As I have said that during my time in the IDF, I would like to focus the treatment of GDM because this could be one of the major issue, because that it is so-called the whole pattern of the fetal programming, that I myself is now running a kind of large program supported by the European Union grant in about 11 different countries, where we wanted to see that what is the impact of the fetal program in different ethnic population, in different ethnicities. And there is where there is an option, and in the next phase probably we'll try to do some intervention in order to modify the so-called the fetal programming. So I believe that this is very important part if we are thinking of the prevention of diabetes as a whole. So I think this is one of the things that I would like to focus, and I hope that I will have your support in order to do this. But at the moment, I said that I am cautiously optimistic about metformin, but we do not have any scientific data yet, robust data yet, to say that, well, we recommend such a thing.
Question to Dr.
And,
Mithun.
what would be the maximum dose you would be preferring to start with the gestational diabetes?
Yeah, this will obviously depend on the level of glucose dysregulation that you see. Whether depending, I would rather say that in order to go for a kind of a definite dosage, I would rather like to see that whether we should have, for example, the gestational diabetes, the so-called the lower rate, the medium rate, and higher rate. So these are my thinking that whether this could be, we should be adjusting the dosage in terms of the level of glucose dysregulation that we see in women during their pregnancies, instead of saying that one first dosage.
Okay, so thank you. Arvinda, please.
Next question to Dr. Mithun. Some person has asked, like, what is the cutoff point for premature ejaculation? Do you give tadalafil or any other PDE5 inhibitors on a day-to-day basis to avoid the boredom of corona every day? You told only weekend.
Okay. So that
Arvinda is enjoying it, you know.
I know.
The way he's asking, he's enjoying it.
So sometimes what happens is a very important thing, because all our friends, I can crack a joke at Dr. Aravinda. Generally, when somebody in my group, when I go to a party and somebody asks me, my friend is asking, generally he's the person who's asking. So Dr. Aravinda, I'm catching you right now. But okay, so there are two questions here. Premature ejaculation. I think the term is wrong. Nobody has sex with a stopwatch. Nobody has sex. We don't put the watch on and we don't put the watch off. We have sex for two reasons: procreation and recreation. Procreation is to have another child. Recreation is to enjoy sex. How can you put the enjoyment of sex is with a timing? Because it is well proven fact that in adolescent years and in elderly, people do not ejaculate. Does that mean they do not have an orgasmic sex? So the word is more about orgasmic satisfaction rather than ejaculation. Now, putting it in lay terms, because very difficult, we can have a section on premature ejaculation, but people still want to because they don't want the time to have. And there was a big meeting in International Society of Sexual Medicine, and they agreed about around less than around a minute is called premature ejaculation. If you actually have to put a term to it. But I think the important factor is, what do they mean by premature ejaculation? There are various ways of both the men and the women of orgasmic satisfaction, and it is not time bound. That is one question. The second question was, during COVID times, what was the question, Arvinda?
So do you give only over the weekend or on the daily basis? Is there any side effect profile?
It is upon the need of the patient. See, very often there was an ad of Chavanprash, 60 saal ka buddha ya 60 saal ka jawan ya 25 saal ka buddha. It depends on your frequency of coitus and your need for which you will be taking the PD5 and which PD5 you will be taking. It is not defined upon COVID times. COVID times may also have the child in your bedroom. So that may also affect, and the school is from the house. So it also depends the opportunity and the timing of the whole game.
Yeah. So Dr. Sandeep?
Mithun, one important question is that long-term users for tadalafil. Suppose somebody is taking 2.5 every day or every alternate day, or 5 milligram every alternate day or every day. What could be the long-term side effect for this? Other than that, which we have the retina complication, and how frequently it should be monitored also.
So other than that, I think if somebody you can give it long term. Most people do not have, it depends, you have to time it with the number of coitus he's having. I think that is a good point in the clinic to ask how frequently you want to take it versus how frequently. If he's having only Saturday, Sunday, Bansibai, then Friday, Saturday, Sunday, he can take his job will be done. It will last till Monday also. So that is that, but there is no unsafety data. No, I'm talking that no negative data about it cannot be given long term.
So then, Mithun, because primarily these drugs were, for the cardiovascular, their clinical trial was done for the cardiovascular trial,
Yes,
and the patient with the established atherosclerotic cardiac disease, why they can't be taken every day? You forget about the part of the sex. I'm thinking in the terms of, does they have a benefit as far as improving the endothelial function? Any data for that? Does it have any other benefit other than this? How it is going to improve the circulation in the penis? The same way, will it improve the circulation in the heart also? That is what, or in the brain also. So does we have any data for that?
Yes, there is data. Sud Ramachandran and Hackett has done a study which showed PD5 inhibitors improves endothelial dysfunction and improves mortality. There are also some papers in the pipeline I'm aware of, it's going to get published, which is showing that PD5 inhibitors is good for that. As you said, the PD5 was derived initially for the heart, and they found that the patients are not returning the tablet and yet saying kuch fayda nahi ho raha hai. but then they found out that their sex life was happy. That's why they're continuing to take it. So long term, it may have improvement in endothelial. I think there is more data that is coming out. For the time being, it can be given. I would not say don't give it, but it should be given alongside the frequency of the quantities of the patient.
I agree, but still, primarily the most of the physicians and everybody understand it's only with the directly correlation with the coitus or number of things. So I just wanted to have, because it's an endothelial dysfunction, with that data, will it help more that, the doctors can and physicians can use it in?
I think it will really help. It will really help increase
And,
the use
and what about this arginine and the other helping medicines which are available?
There is no concrete data on arginine. There is no solid data on it.
Dr. Mithun,
Sometimes the packet of the horse packet on the picture helps more than the actually powder inside.
Oh, great.
Dr. Mithun, your comment about nebivolol, it has nitric oxide donor properties. Any effect on sexual dysfunction, or positive or negative?
All the beta blockers, nebivolol is slightly better. That's what they say. If you have to give a beta blocker, nebivolol is slightly better as compared to the rest. The evidence is A2 antagonist is the best antihypertensive. There's some studies which showed the patients who have got sexual dysfunction, A2 antagonists are the best in terms of the profile. Beta blockers should be avoided, but if they have other cardiac activity, you can't do anything about it.
Dr.
There's
Sachin,
one
question
there's
is,
one
do the patient with long-term diabetes and thyroid are prone for sexual dysfunction compared to the only diabetic patient?
So long-term patient with diabetics. So I published a paper with Sanjay Kalra, which talks about how thyroid dysfunction has an effect on sexual life. I think it's a very important fact that even not overt hypothyroidism, definitely I have had patients who have come to me, have checked their thyroid function test abnormal, give them thyroxine replacement, became beautifully okay. So there is some correlation with thyroid dysfunction and diabetics. So thyroid dysfunction is there because hypothyroidism may increase hyperprolactinemia, which we call erectile dysfunction. So there is a correlation on the endocrine front as well. And I'm sure Sachin will agree on the relation with the prolactin.
Dr. Sachin, your opinion?
Definitely anything which will increase the insulin resistance will definitely lead to hypogonadism. This has been proved every now and then in so many studies. So if a diabetic will lose weight, his sexual dysfunction will also improve to some extent. And with respect to hyperprolactinemia, also it is true. Because if there is hyperprolactinemia and the patient is having hypothyroidism, after correction of it, definitely his testosterone levels will go up. So that is definitely bound to happen. So there are so many interplay of things: insulin resistance, obesity, leading to hypogonadism, hyperprolactinemia. So it is just not one thing, especially in context of diabetes. And the combination of drugs will definitely help.
With the common question is, one common question is there, like at time by Dr. Prabhakar Malya and Dr. Vikram Vasagan, they have asked this question. At times, even 20 milligrams of tadalafil fails to help in those with good glycemic control. Why is that? Is there any harm in increasing the dose? And second one is there any methods to improve penile artery occlusion?
Okay,
All can answer.
First question is very easy. If 20 milligram tadalafil is not working, then you're barking down the wrong tree. You need to get the husband in your room and have a real discussion ki kya ho raha hai bhai. Okay. So if 20 is not working, something is actually wrong. The diagnosis is wrong. You're going down the wrong trait. So that's a very simple answer. Second is how to prevent benign. So basically, how to prevent arterial occlusion. You need to keep your vascular risk factors fine. Stop smoking, cholesterol profile, sugar profile good, physical activity because it's going to increase the blood flow all throughout the body. I think that's all. And also indulge in, a lot of people when they have sex like a 20-20 cricket match. Sex is not bang, bang, thank you very much, ma'am. Sex is a long test match. So you need to understand that, and actually people are not taught how to have sex in India, though even it's the land of Kama Sutra. When we were childhood, 2 flowers used to come in a movie and the child was born. So that was, a lot of people still stick to that.
So
Sorry,
I am
very
sure
serious.
Mithun, in this next 9 months is a big chart. Like by the end of like beginning of 2021, there will be a lot of deliveries. I'm sure because of these Corona times and you being prescribing tadalafil every day. I'm sure the outcome of 2021 will be very good.
Arvinda, why you can't? You can also.
I
So
think next time, Bansibai, we will keep this session before the gestational diabetes because the pregnancy has to happen before.
exactly, yeah. No, actually, Dr. Akhtar asked me, last moment change. Otherwise, he was supposed to give a talk before. It's
Acha.
all fine. So now can we close this session because we have to move to the banting hall also. And I just want to give thanks to everyone. We have a lot of discussion and it's almost end. We have to finish by 6:30.
Thank you.
Dr. Jimit, can we have? Dr. Jimit? Yes. So can we close the session here? And I just want to give thanks because I just don't want all of you to move to the banting hall just for the vote of thanks. But one of the biggest thanks to each one of you, all the faculty members, all the speakers, all international faculty. One of those just Dr. Akhtar Hussain, who is a very close friend of mine, who is IDO President-elect. And I'm really thankful to all chairperson for very nicely moderating the all sessions. I'm thanking Dr. Jimit since last yesterday. He is there from 1 p.m. to today 6:30 almost. He's there all the time. So I'm really thankful to him. And I'm thanking Dr. All other by Pratap Jethwani and everyone. I'm moving to the hall A and you can close now this hall. Over to Shashank. I'm just coming in the hall A. So thank you, Jimit, once again, and thank you all the speakers, all the faculty members, all the chairperson, moderator. Thanks to Dr. Hardik for a fantastic show, virtual platform, which he had provided us, along with Abhishek from Delhi and all my diacate